You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. In this episode, I sit down with Dr. Minal Shah, Medical Director of Virtual Care and System Medical Informaticist at CommonSpirit Health, who's helping shape the future of care delivery at the intersection of clinical practice, technology, and strategy. We dive into how thoughtful technology design, like AI scribes, Epic monitor, and real-time location tracking, can reduce cognitive burden and improve clinical workflows. Dr. Shah shares lessons from building a digital-first hospital, the importance of de-implementation, and how communication norms can protect clinician focus. If you're leading digital transformation or optimizing care delivery, this conversation offers practical insights you won't want to miss. Let's plug in. Dr. Minal Shah, welcome to the podcast. How are you today?
I'm great. Yeah, thank you for having me.
Where do we find you today?
I am in Colorado Springs, Colorado.
So tell us about yourself. What do you do for a living? And I kind of started us off by calling you doctor, so I think that you might be a doctor.
I think I might be as well. Yeah, I vaguely remember going through 4 years of grueling curriculum in med school. So yeah, I am an internal medicine hospitalist, still practicing. I am with CommonSpirit Health, so I've been here for about 6 years. And I wear a lot of hats within CommonSpirit, so I kind of operate at the intersection of clinical care, technology, and strategy. I'm a physician informaticist on our national informatics team. I am a medical director of virtual care for our telehospitalist program within Mountain Region, and I spent some time starting up our innovation hospital here in Colorado Springs. So get to do a lot of really fun work.
How did you get into the kind of the technology aspects?
I think I was informally involved with EHR implementation, as many of us were, just by virtue of seeing our hospital systems go live with Epic. But I started my formal work with informatics in 2022. And actually in 2021, I kept getting these ads for a Stanford AI and healthcare conference. So I decided to go and see what this AI thing was all about. And it was really enlightening. It was like a light switch for me. And I decided I really wanted to be involved in this work. It's where I saw my first demos of AI scribing technology. And I saw the power of predictive analytics with machine learning. And so I then started to think about what kind of doctors get to do this work and pivoted my career in that direction. Yeah, this was pre-Chat GPT. So it's kind of the Stone Age, I guess.
So it was an AI conference, but you do more than AI. You're involved in some aspects of implementation of the electronic health record. Tell us about all of that work.
Once I decided I wanted to start working at health technology, I started exploring the avenues to do so. Thought about startup advisory work, thought about entrepreneurship, but, I actually really like leading at the health system level. And so that's when I learned about this field of informatics. I took an AMIA 10x10 course, and I realized I actually like the full spectrum of informatics work. So not just AI implementation, AI deployment, but optimization, quality, safety, implementation, change management, innovation work. I kind of like it all. So yeah, I've gotten a lot of opportunity within CommonSpirit to lean into my interests, and it's been a great few years.
Well, let's start off with something controversial. Poor quality clinical decision alerts. Now, you've said, I believe, that you like those. The poorer the quality, the more you appreciate them as a practicing physician, and that your colleagues appreciate them. Did I get that right, or did I put that the wrong way?
I mean, doesn't everybody like to be interrupted every 5 minutes with useless alerts? I think we all feel that way.
I know I do, but I used to work for an EHR vendor a long time ago, so I clearly cannot be trusted. So, all right, so let's change that to say that most people don't like alerts that are not helpful. I think we all actually seriously like alerts when they remind us of something that we were going to forget to do, or suggest something that we hadn't thought about and at the right time in the workflow. We all want those. How do we get those instead of reminders that take up the screen that we have to dismiss somehow to tell us to do something that we were just about to do?
Yeah, I like to think of alerts or clinical decision support as interruption with a purpose. And so for me, that means surfacing the right information at the right time, but also with the right intensity. I think those are the three components I kind of look at. And then I also think that, you have to make sure that the alert is an important enough problem that the clinicians actually want to act on and need to act on. So I think about, is the alert important? And I match the intensity of the alert to the importance. If I'm about to order, say, a massive overdose, I want that in bright red, really alarming me. If I'm about to dose something 4 times a day instead of 3 times a day, but it's still acceptable, I don't want that in my face. I want that to be kind of quietly working in the background or suggesting in other ways. And then I think another big piece that we forget is it actionable? So, surfacing information to clinicians that's not actionable can be viewed as highly interruptive. So we want to be able to provide or suggest an action for them. We want to be able to do it in line with that alert. And we want to be able to have the clinicians provide feedback on those alerts as they see fit. That's kind of how I think about how to design a good alert.
So first of all, I think that's all brilliant and definitely the direction that everyone should be going in for the last 20 years, unfortunately. Something that I think that you wrote about was and I'm not sure if this is your phrase, the interruption tax. This idea. Yeah. Tell me about the interruption tax, and do I still have to pay it in Colorado if I don't live there?
Yeah. So I call it the cognitive tax. And I describe it that way because it's taxing, right? It's cumulative. If you get interrupted every 5 minutes on your shift, you are less able to make decisions. You're more frustrated. You can't really complete tasks in the same way. And so, I always use the phrase, don't make clinicians pay the cognitive tax just to use your tool. You're not going to get good adoption that way. You really need to think about how to design your workflow so that you are surfacing these insights as the clinician needs them. You're providing an easy workflow to kind of close the loop, and then they can move on. So I think a big piece of that is task completion. Complete one task before you move on to the next task.
And this is not unique to technology. I'm aware of pharmacists or nurses who are preparing certain medications, standing in an area that's cordoned off by red tape on the floor. And, I've seen this before where, hey, if someone's in that rectangle, that means that unless there's a big emergency, you're not to talk to that person because they are in the middle of making sure that they have the right IV or putting the right ingredients into an IV bag. That cognitive load is significant. And I love what you were saying about that, the concept of the alert, making sure that I'm done with this task before we start thinking about the next task. We realize multitasking doesn't really exist. You're stopping one task and moving on to the next, and then you have to kind of try to recover from where you were in the last time.
I would agree with that. There's this great article written by by a business professor out of University of Washington. Her name's Sophie Leroy, and she wrote this article, and I think it was called "Why Can't I Get My Work Done?" And it describes her research in task completion. She calls it attention residue. But the idea is until you complete one task, your focus is, if you move on to another task before you complete the first one, your focus is still somewhat on that first task. And so you're just less efficient in completing work after that. And I think it applies to healthcare, not just healthcare technology, but as you mentioned, it's the very nature of the work that we do. And many of our interruptions are clinical, so they're appropriate interruptions. Some of those interruptions are kind of more quality and safety based, like a surgical checklist that you do before you, like a timeout checklist. But a lot of them are driven by technology. And so I just think as people who work with the EHR and other emerging technologies, we really need to be cognizant of how interruptive we are, because I just think that attention and focus are two of our most precious resources while we're working. And I don't know about you, I feel like the number of interruptions, it just compounded dramatically over the last 10 years. Interesting story. I actually was working at a less busy hospital over the last year and a half. And it was such a stark difference. I went back to the busy hospital maybe 6 months ago, and I was just constantly getting bombarded. Once you kind of have that reset, you realize that it's really every 5 minutes, every 2 minutes, I'm getting interrupted. I can't finish a task before I move on. And I wonder if for some of us that have been practicing, if it's kind of a frog in boiling water situation, like you just continuously adapt and adapt and adapt. And until you get a break from it, you don't realize how big a role interruptions play in your workday.
Yeah. What can you do? One thing that I've caught myself doing is, and I've seen other physicians do, is replying to, I'll say text, but really just messages, often through a secure messaging system, either through the EHR or a standalone system. But nurses saying thank you, which is just common politeness. Hey, can you put that order in for that thing? Or, hey, do you want to do option A or option B for this patient when this thing is happening? And then you reply, and then you get back, thank you. And which is great when you're having a conversation, but can be kind of horrible when you're just sitting down to start talking to the next patient and you have to now look because you got a text message. And it's not something that requires your attention, but there's no way for you to know that at that time. And I've seen hospitals create like etiquette guides to say, please, we want you to be civil and we appreciate the thank you, but don't send a physician a thank you. If they've done what you asked them to do, thank them by not sending them a thank you message.
Yeah, absolutely. And I 100% agree with that. Those thank yous compound over a 12-hour shift. If I get a thank you for every task that I complete, I mean, that's like an extra 50 messages sometimes. I strongly believe, especially with secure texting platforms, that you can't just release the tool into the wild. You really have to have communication norms. And that helps the providers, but it also helps the nurses as well. One that I always say is thank yous are reply. So we all respect each other. And so, please don't take up that valuable, time by saying thank you, or say thank you in your first message or thanks in advance if you really feel the need to be polite. But having those communication norms really help everyone, right? It's important for nurses to know what the escalation policy is. It's important for nurses to know when should I expect to hear back from my providers. All these pieces play a role in how interruptive this technology should be. There's a really great NEJM article from a few years back. It was called like the ecology of attention or something like that. And I loved how they talked about just in some ways we're more reachable than ever, but that hasn't really led to more meaningful interactions with our colleagues or our patients. We really have to think about balancing that reachability with meaningful interactions. So I think having those norms set up help protect everyone in terms of how frequently they're interrupted. And that's not necessarily a technology, an IT function. That's also an operational function. So to some degree, we have to think about organizational change as well to be able to protect the attention of our clinicians.
Yeah. It's funny that you mentioned kind of setting norms and especially around communication. I'm kind of old. I've been doing this for a while. When I started practicing at the hospitals, at least that I was at, if you put in a consult, if you ordered a consult for a patient before you talked with the physician who was going to be consulted, that was bad. That was bad. And you wouldn't do it. It just wouldn't happen. It was just, hey, I'm going to be consulting you for this. This is the general question. I've got all the details in the consult. Is that all right? Do you have any questions, or is there someone that I should better consult than you? And it was just a quick call, and people expected it and were upset if it didn't happen. And that was the norm. And I've run into kind of a couple times where the technology is changing the norms. And it's not necessarily the technology's fault. It just, people are like, well, why do I need to talk to another human? There's a great example when I was the CMIO at a hospital system. And someone came to me and said, hey, we need a solution for this problem. We have babies that are fetuses that we detect, fetal hydronephrosis on, and during their mom's scan. And most of those babies are fine. We just need to kind of follow up after they're born and get a kidney ultrasound for those babies. But we do need to follow up to make sure that they're fine, because most are fine, but not all are fine. And hey, we need you to figure out how to do that in the electronic health record. And I said, well, I know how to do that. The obstetrician, after delivering the baby, calls the pediatrician or the family doctor. And it's a phone call. And you say, hey, there was some fetal hydronephrosis on the maternal scan. Just making sure you're going to be taking care of this baby. You may not know it yet, but you are. And wanted to make sure that you ordered everything that you needed to order as the physician for this brand new patient. That was just a gimme. Like, that was the OB figured out who the pediatrician or family doc was and called them. It wasn't complicated. And I pushed back as the CMIO, and I said, this doesn't sound like a technology problem. This sounds like a communication problem, and we're going to need to work this out. And, that was just something that happened. And I think we're losing. The technology doesn't necessitate that we can't use the phone, but it makes a lot of people think I don't need to use the phone anymore. And it's not good for anyone. It's not good for us as colleagues. It's not good for the patients that we care for.
I agree. I was taught the same way. I was taught that your sign out to another provider when requesting a consult is critical as well. And I think it does help you build relationships with your colleagues. And then you also kind of surface more insights when you talk to another provider on the phone. You might ask a couple of questions, or, you might get asked a couple of questions, and all of a sudden you're kind of collaborating together. You just can't do that with a consult order in the EHR. And I think it goes back to that idea of, we're more reachable, or there's less friction to be able to do some of these tasks, but you're not really creating a meaningful relationship. And that's, healthcare is in those meaningful relationships. It's how we create that cohesiveness as a team. So, yeah, I agree.
Most of us would rather, if I don't have to have a call, that just gives me another minute to do something else. But to your point, the things that you just accidentally pick up on, like, hey, is this like that last patient you sent me? Actually, yeah, it's just like that last patient. Okay, great. Like, that's never going to be you're never going to put that in the comment section. Just like the last patient I sent you. Even if it's true, that's meaningless outside of the context. We just kind of talked about some things that we stopped doing that we shouldn't have stopped doing. What about things that we should have stopped doing? And the term I'm going to bring up is de-implementation. So stopping some of what we've done when we do digital transformation. And it's, most people, when they think of transformation, digital or otherwise, they often think of adding things. We're adding technology. We have a new workflow. We have a new application. They don't often think about stopping things. So what are some of the things that we should think about stopping, and how do you go about doing that?
I think most EHR focused work we do, for example, it often doesn't get fully de-implemented, but it should be reevaluated periodically and updated and adjusted. Like, it should be an iterative process when you're pushing out a tool. So I think it's important to have governance processes in place to be able to periodically review how well your tools are doing. Not my tools. Everything I build is actually perfect right when I build it. But for other people...
That's assumed. For other people. Right. Yeah.
I'm joking. But, for example, our order sets, we review those periodically every couple of years. If there are issues that are brought to our attention, we review them more frequently. We look at things like usage data. We look at clinical guidelines, how they can be updated. I think it's rare to completely de-implement something, sometimes because we spent a lot of time building it, so it's kind of hard to let go. But when you see data that your tool's not working, I think you really need to consider just de-implementing it altogether. And it becomes a maintenance issue as well, right? It's interesting. We are moving towards a national instance of Epic with CommonSpirit. So I led the note template work for that. And so I reviewed tons and tons of note templates. I think it must have been thousands of note templates from our region, mountain region. And it's amazing the number of templates and smart phrases out there that have like one user over the last 30 days, and so you at the time, it's like that physician or that provider was like, no, everyone's going to use this. We absolutely need it. But when you look at the actual usage data, you realize that could have been a user smart phrase. You could have shared that with your group, and we don't need to maintain it at a system level. So it was kind of a unique opportunity to take a wholesale look at all of the templates that we had built and think about how can we let go of some of those, or how can we kind of shift those to user-centric templates and moving forward, keep something that feels easy to maintain. So it's hard to admit that things that you built are not being used, but it's important to look at that. The other thing I will say is that when you're talking about de-implementing something, say, or even changing something, say I'm changing the clinical content in an order set, that affects real users on the ground. So I think it's important to get feedback from clinicians in that moment and to really think about the change management plan on the other side of it. Because if I use the same order set every single day, it's predictable, there's an ease of use for me. If you take that away, if you change it, then I need to know about it. I don't want to find out about it just because suddenly everything has changed. So you need to think about the cadence with which you change things. You can't change an order set 6 times in a year, for example. And you need to think about the change management, the communication piece on the other side to your end users. It really starts with the clinician when you're designing something, and it starts with the clinician when you're de-implementing it. Something as well.
One thing I wanted to kind of talk to you about is this hospital that you were involved with in the construction. Tell me about this. This is St. Francis Interquest Hospital, and it's a kind of digital first hospital. Yeah. How did you get involved and what did you do? Tell us everything.
Yeah. So that project was actually led by our former CMIO, Val McInnes, and our former CISO, Sanjeev Saha. I came on a little bit later in the project, but I think the story is really interesting how they were involved from the very beginning. So that hospital, IT and informatics were involved before we even broke ground. What they did was they put a bunch of clinicians in the room. So nurses, therapists, surgeons, hospitalists, I put everybody in the room, and they just had them think about what are the most annoying things about working in the hospital. So they started with those pain points first, and then they went looking for solutions. I think it's really easy to go the other way around. There's so much great technology out there, and everyone gets very excited about how to build a smart hospital. But one of the things I liked about this project is that CommonSpirit really started with what clinicians needed first. So one thing that came out through those conversations is it's really hard for me to find things. Like I spend a lot of my day hunting down the bladder scanner, the ultrasound machine, hunting down my physician. I don't know whether they're in OR. I don't know where they are. And so, out of that frustration, we built RTLS tracking throughout the entire hospital. So we use real-time location services. We tag all of our equipment. So the nurses are not hunting for things like bladder scanners. They know exactly where they are. They know where their physicians are. They know if their physicians are in the OR because we have our TLS trackers in our badges. It really helps us be more efficient. We're not spending all that time looking for people and places and things. It's all kind of right there at our fingertips. So that's just one example. But what I loved about this project is that it started with the pain points of the clinicians first. And on the other side of that, when we opened this hospital and when we started the implementation of all of these new technologies, we saw widespread adoption because it really fit the needs of the clinical staff.
If you give the people what they want, they jump up and down. It's funny when you said I can't find things. I thought you were going to be talking about the electronic health record, and I can't find the information I need. But in fact, I can't find the doctor. I can't find the piece of equipment. When I was practicing, there were times where I couldn't find the patient.
Exactly. And that's part of the value to the providers of that hospital is I'm not going to go try to round on somebody that I can very clearly see as an MRI. I'm not wasting my time doing that. I will say that my daily step count went down considerably. So that's, a problem.
That's a negative.
That's a negative. Yeah. But other than that, I'm certainly far more efficient than I was before.
That's awesome. That's not high tech, right? Like the idea of RTLS it's just not, there's no AI in there. It serves the purpose and solves the problem. And it's the simplest way of solving that problem. And I think sometimes often we try to over-engineer and use the latest technology, use an AI to predict where the patient would be.
And out of that idea, other ideas kind of came about. So, we've got trackers that are badges. So when I walk into a room at that hospital, my name and picture flash up on the screen for the patient, which is another thing that was kind of born out of the, kind of COVID-19 period where we were all wearing masks. But there's so many little things you can do to enhance that patient experience and also enable your clinicians to work more efficiently. So we're very proud of what we built there. I would love to show it to you if you're in Denver anytime. Come down to Colorado Springs. We'll give you a tour.
Another project, and maybe this overlaps with what we were just talking about, is the Epic monitor. You had mentioned that when you come into the room, your picture appears. Talk to us about that project. What is an Epic monitor, and what surprised you in terms of that project?
So an Epic monitor is essentially a digital whiteboard, and many other institutions it functions just as that. It's kind of a static board that tells the patient what's going on. Clinicians can update it. But we reimagined what that Epic monitor could be. So our Epic monitor is a large screen. When at rest, it does function like a digital whiteboard. So, you can write messages on it. You'll see who your care team is, et cetera. When a clinician, either a nurse or provider, therapist walks into the room, it flips into something called clinician mode automatically. And so there it displays kind of all the pertinent information you would need to round on your patient. Vitals, imaging, medication list, problem list is all up there, and it's touchscreen, so it's interactive. So I can actually open up the lab section and I can show my patient the lab trends. I can open up imaging and I can visually show them a CAT scan or an X-ray, and I can talk them through it. I can pull up their med list and show them when they last got their shot of morphine. All of those pieces are, instead of being kind of a static board, it is an interactive tool that we use during rounding, and our patients absolutely love it. What I was surprised by, I was surprised at how many elderly patients really love that Epic monitor. I think we all have that misconception that older patients will be less accepting of technology. But when you design something that patients really want to use and you're using it as a way to enhance how you take care of those patients, it makes a huge difference. So that hospital specifically focuses on orthopedic patients. So we do get a lot of older patients, and they love it. They love being able to participate, be an active participant in their rounds. You're kind of taking a passive patient and you're activating them by, giving them some visual stuff to anchor on.
Yeah, that's great. And I feel like that's a problem. This concept that older folks are not as digitally savvy, or at least not interested in anything digital, from the patient portal to electronic whiteboard. They may not have the latest iPhone in their pockets, but they often are very interested in getting that information and leveraging it. Well, that's great. So that sounds like that was another successful project.
Yeah, it was really exciting, and our patient experience data really reflects, the value of some of those tools that we've built to just make things a little bit easier for people when they're hospitalized.
Let's talk a little bit about AI. Some folks are excited about it, from AI scribes to predictions, predictive AI. What are you excited about?
AI scribes really soften the sentiment of physicians towards AI, in part because they solved such a important pain point for physicians. And I think that's why we see the adoption has been so dramatic for those tools. One of the things I'm excited about is how we can take those tools, which right now focus mostly on documentation, and how they can be built out to truly become kind of copilots for our providers. So some of that other work in managing the EHR that can be burdensome besides documentation, dynamic data review, proactively placing orders for me, or proactively teeing up orders for me to complete all those other pieces that are frustrating about using the EHR, I think are a great opportunity for some of these AI scribe companies or other companies that may be moving into that space. So that's one area that I am excited about. Another area I'm excited about is using other data besides text data and audio data. So using video data, for example, to be able to look and interpret video data and provide insights for us. Some of the companies are coming out with like fall detection using video, or benchmarking progress in the OR using video technology. So anywhere where there's a vast amount of data that a clinician has to process, I think there's immense opportunity. So I hope to see that continue to progress. And I'm optimistic.
Most of us have played with ChatGPT at least a little. And so we kind of understand what generative AI is. But there are other sorts of AI. And I think to your point, it doesn't have to always just be words or numbers. It can be video and audio. And I'm aware of a company now that is can screen you for anxiety and depression as accurately as validated instruments.
So did they use a voice AI tool for that? I think that's the other really exciting technology is, kind of outbound voice AI.
Yeah. I was talking to some of the folks from that company and I said, who's using this? Because it seemed kind of odd that people would be like, yes, please analyze me and tell me if I'm screening. Not that I'm not diagnosed with anxiety or depression, but most physicians want to make sure if they do have patients like that they are referred to the proper folks. And the benefit to them is, hey, when you go to the doctor's office, we don't have to ask you you don't have to fill out these questionnaires that we all have to fill out all the time. And it's one of the really amazing things of AI that hasn't certainly not standard yet, but kind of going in that direction. I always like to end with the same question of all of our guests. And the question is this: is there something that's so well designed in your life that it brings you joy whenever you interact with it?
Yeah. Just to give you some context, I just traveled with my two little ones on a trip for the long weekend. So I have a 4-year-old and a 17-month-old, if that gives you some context. And the hardest thing in my life, I think, is getting them from like the airport parking lot into a seat on the plane. That is like a Herculean journey for me. And I have this amazing stroller. It's a travel stroller. It collapses with one button. It can be lifted with one hand, and it expands with one button as well. And it truly brings me joy. I mean, it is just, I think it's an engineering marvel. I might be biased, but it's really made such a big difference in my life. Juggling 2 kids, and they're screaming, they're crying. It's midnight. It's great to have.
That is great. That's an amazing tool, and one that it can decrease your anxiety. We don't even need to check and screen you for anxiety. We know you have anxiety when you're taking 2 tiny children to the airport. Well, Dr. Shah, thank you. This was great. It's a great conversation. I am excited to see how that new hospital kind of works out. It was great. I look forward to stopping by whenever I'm in Colorado Springs and to see all of your good work and look forward to see all the cool things you're going to do in the future.
Yeah, absolutely. We'd love to have you. And thanks for having me on the podcast. It was great chatting with you.
Thanks. Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Shah, follow her on LinkedIn at linkedin.com/in/Minal A. Shah. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.